So for diaphragmatic hernia, I will talk about the exact diagnosis and prognostication. I will speak about prenatal therapy, which I summarized in my previous talk, and about the trial. So what I always have to do is to mention to gynecologists, yes, it's a hole in the diaphragm, but no, the disease is in the lung. They have smaller airways, abnormal vessels, and abnormal compliance. This is why 3 out of 10 babies die from this condition in the postnatal period. The question is, can we find these? Now, 30% mortality is still all over the world the same. I mean, the US still have this arrogant attitude that there is 105% survival in the United States, but in their publications here, you cannot see that. Now, I will give you new data that are published this month in the American Journal, that shows very interestingly the miscommunication that you have between a fetal medicine specialist who starts counting in the first trimester and a pediatric surgeon that starts counting on the operation table. Mount Sinai Hospital and Sick Kids are the same hospital divided by a big road in Toronto. The survival rate in that center is quoted always to be 85 to 90%. It is not true. If they count in Mount Sinai to begin with, 15% of the patients undergo termination. And retrospectively, they are the worst. They never get into the statistics, hidden mortality. The second thing you see is that crossing the road has a mortality of 20%. That's a very dangerous road, I would say. Babies that do not make it to the sick children's hospital cannot be resuscitated. They die in the first hours of life before they can cross the road. So the loss here is 20% that never shows up in the statistics. How can we predict that? We do so based on lung size and on liver herniation. You can see here the vessels, and that's the liver. And that we bring into a formula. We measure the lung-to-head ratio. You measure it in the case that you are dealing with, and you're going to calculate how much you need to have in a baby that has the same gestational age. And the cutoff you have to keep in mind is 25%. It's more or less a lung-to-head ratio of 1. But this takes gestational age into account. Lung-to-head ratio is gestational age dependent. This is the algorithm that I already showed. So you bring into the equation the lung size and the position of the liver, and then you have this plot. Lung-to-head ratio is also predictive of morbidity. The number of babies that need a patch with a very small lung, under 25% is 75%. Need of oxygen, days on the ventilator, days in NICU, all dependent on lung-to-head ratio. We can measure today in 3-dimensional techniques, but what you can remember is that 3-dimensional does not predict better so far. I will not go into it because it's a debate, and as long as it is not solved, I don't think we have to do it. The group of Barcelona has been doing tremendous work in trying to predict outcome based on the arterial side of the lung. By looking at resistance, fractional moving blood volumes, we looked at hyperoxygenation. You can forget them today. They have only been validated after fetal therapy. You cannot use it today in your counseling. So what are we doing? We can occlude the trachea, and we can do so by fetoscopy rather than by open surgery. Tracheal occlusion does the same as congenital high airway obstruction. It leads to big lungs. So occluding the trachea prevents the lung liquid to go out of the alveoles. That is a signal for growth. Unfortunately, the number of type 2 cells then is completely knocked down. For that reason, you have to reverse the occlusion, and then you have normal surfactant and a bit normal vessels. So the fetal surgery consists in 2 parts, that is plugging and unplugging the trachea. This we have shown just before we went to this part of the talk, of the afternoon session. And here are the results more in detail. The number of babies that will deliver early is very significant. About 25% of the babies will be born prior to 34 weeks. That means you will have to remove the balloon in an emergency situation. The rupture rate is a direct predictor of preterm delivery. It's the main cause. And rupture of the membranes is completely dependent on the operation time. So that means if you're going to do such a program, you must concentrate cases. Otherwise, you build up never experience with this procedure. The balloon can be retrieved, as I mentioned, by fetoscopy or by needling. The majority of cases are handled like that, even by Kypros. And I can tell you he's not afraid to put in a needle. We always try needle first, otherwise we do fetoscopy. And we try to avoid postpartum or peripartum retrieval. Again, here the survival rates. For right-sided diaphragmatic hernia, it is from 0 to 35, and for left-sided, the increase in survival is around 30%. It's dependent, again, on the lung size, the time point at delivery, and the ability to remove the balloon. We do not substitute mortality by morbidity. I will show you that in a second. But first, take a step backwards. Here is the 25% of babies that will be born prior to 34 weeks. And this is the majority coming later. And you see here the survival rate under 32 weeks is around 20%. That means that fetal surgery does not kill babies. The survival rate is the same as you expect at term, even if it's born 8 weeks earlier. And after 32 weeks, the survival rate is around 60%. And it doesn't increase any further. That means that the balloon has to go out at 34 weeks and no later. This is morbidity in 90 cases that underwent fetal therapy. Same slide as before. And here you see that the oxygen need, days on the ventilator, days in NICU goes down, days on the ventilator. Of course, the defect doesn't shrink and the need for a patch is the same. So fetal surgery does not substitute mortality by morbidity. Today we are doing a trial. This trial is called the TOTAL trial, tracheal occlusion to accelerate lung growth. It is actually two trials, one in severe cases where we do an occlusion 1 week later than we used to do in the past. And the trial has started, and the 5 North American centers have agreed to participate. It's the first time there's going to be a trial on both sides of the ocean. And then in moderate cases, Eduardo Gratocos and myself are the only ones doing this trial at this moment, and we have included 43 patients already, and the interim analysis point is there, and we do late tracheal occlusion to reduce the morbidity. Any questions? How many? Oh, the problem for that is that not all the centers offer ECMO. We are an ECMO center. There are many centers in Europe that don't believe in ECMO, and as a consequence don't offer it. For the centers that are doing ECMO, the ECMO rate is around 13 to 15% after fetal therapy. It's very low. But that is because they have very stringent criteria for letting the patient into ECMO. And so they don't start even if they have not a minimal oxygenation and CO2 level, maximum CO2 level. So it's difficult to say.
¿Alguna otra pregunta? Doctor. The balloon that you use to put into trachea is it is able to keep the pressure enough inside the the lung?
The only way it will go out is by spontaneous deflation, which has happened, or in cases with eventration, and we don't know why. They certainly have the same trachea, so there must be another force there. But that's an observation in 4 cases only. And we reinserted the balloon, went out again.
Good. ¿Alguna otra pregunta?
Thank you for that question. Sorry for not mentioning it. It's my fault. It's published. Tracheomalacia is something that has several definitions. Tracheomalacia, strictly speaking, means disorders of the cartilage. It doesn't happen. We have a follow-up study on our own patients until the age of 7 that shows that the babies have tracheomegaly. They have a larger trachea, and their trachea grows at a different rate later on. So by the age of 4, they already have a more normal trachea than at birth. So yes, you have widening of the trachea. It is not clinically relevant. There is another study that we've participated in where they have done systematic fiber endoscopy, and you see floppiness of the pars membranacea. It leads to a barking cough at effort. None of the babies that we managed in London itself, in Leuven or in Barcelona, had clinical tracheomalacia. There is a paper about 4 cases, but if you read it, it was all mismanagement at the time of removal of the balloon. It only says something about the management and not about the trachea. It's published in an issue of European Pediatric Radiology.
¿Alguna otra pregunta?
We have to make a choice between the bladder and the thorax.
Bladder?
Is the bladder full? Okay.
Bladder, yeah.